wound or cancer wound. Okay, so in our setting, when we see a cancer patient, we can see this kind of wound. Have you seen it? Now you can respond. The image has been shown. Now you can respond. So this kind of patient, any patient who have been gone through this kind of wound, have you seen it?
Yes, ma'am.
Thank you. Thank you for responding. So, okay. So it looked like something like a cauliflower shape, right? Cauliflower shape it looks like, and it can also be said that nodular fungus. Okay, nodular fungus also, or it looked like a cauliflower shape. So the general idea, what is fungating wound? It is a type of cancer wound, or it is a cancer wound in which it is a primary or secondary malignant growth in the skin which has ulcerated and difficult to heal. Okay, so the primary and the secondary malignant growth means initially there will be a small nodular type, and then after that it will be progressing, right? So the malignant uncontrolled growth of the cell will be taking place, and that area will be ulcerated and difficult to heal. So what is the difference between the normal wound and the fungating wound is normal wound can be prevented and healed, right? There are possibilities the normal wound can be healed and prevented, but in the fungating wound, the healing process is not possible. It will be looking like a what we can say ulcerated and difficult to heal type wound, and there is a malignant growth of the cell, that is extra over controlled growth of the cell will be taking place. And the term fungating refers to a malignant process involving both the ulceration and the proliferative growth. Okay, so in this, what is happening? The uncontrolled cell will be leading to the ulcer formation, and that ulcer formation will lead to extra proliferative growth. Okay, so that because of that extra proliferative growth, it will be looking like a cauliflower shape or nodular fungus type, right? So I think your definition is clear. The normal wound can be healed, but the fungating wound is non-healing, and it is malignant growth in the skin leading to ulceration and difficult to heal. Okay. So we look into the pathophysiology. We all know that the cancer, whenever there is a skin cancer occurs, there is a small nodule, skin nodule formation that is non-tender. So there will be a development of non-tender skin nodule, and after that there will be a enlargement of the nodules. Okay, so we know that because of the overgrowth of the cells, the size of the nodules will be extended, right? So there will be an enlarge in the nodule size, and that enlargement will lead to the disruption of the capillary and the lymph vessels, right? So the nearby capillaries and the lymph vessel, there will be disruption. That will lead to what will happen because of that disruption, coagulation processes altered, and that will lead to disorganized circulation. So the improper circulation will lead to tissue hypoxia. The cells will not get proper oxygen supply. That will lead to tissue hypoxia, and finally, because of insufficient oxygen supply to the cells, there will be necrosis, that is tissue cell death. Okay, so this is the process, that is there will be a non-tender skin nodule. Because of that, the nodules will enlarge because of over growth of the cells. The nearby lymph nodes or capillaries will be disrupted, leading to impaired circulation or disordered coagulation. That will lead to hypoxia and necrosis. Okay, so next, Marjolin's ulcer. Okay, Marjolin's ulcer it is also a type of malignancy of the skin in which there will be a malignant changes in a chronic wound. You would have seen a chronic wound, a long-term progressive wound, that, for example, like burn scar, pressure ulcer, venous leg ulcer. These type of wound, chronic wound, will not be healed, like unable to heal in a particular time period, right? So that ulcer will lead to malignant changes in the skin, and that condition is called as Marjolin's ulcer. Right. So what is the difference between a fungating ulcer and marginal ulcer? Fungating ulcer, we know it is a cancer wound, right? So marginal ulcer is basically the chronic wound, the chronic type of wound. For example, burn scar, pressure ulcer, venous leg ulcer. These kind of chronic wound will not be healed. That ulcer in the surface of the wound, in that the skin will be having a malignant changes, and that kind of wound is called as Marjolin's ulcer. Okay. So what is the pathophysiology of Marjolin's ulcer is? appearance of a mass in the wound. There will be a mass in the wound. The wound will in the wound area there will be a development of mass, and we can that is it look like a mass. The wound will be looking like a mass, and onset of wound pain is not previously present. Means previously the wound was there in the patient, right? But that wound was not that much painful. But when it is converted into a malignant growth, that type the chronic wound will be extremely painful, and that will lead to changes in the character, volume, appearance of the drainage. So earlier there were no any oozing present, but now what will happen because of that malignant changes in the skin or the wound cells, that will lead to changes in the character, volume, and appearance of the drainage. And how we can further identify that what kind of wound it is? By biopsy, by surgical consultation. By sending the patient to the surgical consultation, we can get the biopsy and we can identify what kind of wound it is. Okay. So whenever there is a wound, we know that this problem will lead to all the four aspects will be hampered. All the four aspects means physical, psychological, social, and the spiritual. Right. So these problems will be very like we have to deal with it. Right. So we look into one more all the dimensions one by one. That is physical. So physically, the patient will be having pain. Right. Okay, so pain we can manage it by analgesic, and there are particular pain which is not relieved by the analgesics also, right? And even we will go to the higher level of the opioids also. Some pains are there which is not manageable, but we will deal with. We know that in the physical symptoms, the pain is one character which is present. Then in the wound there will be a malodor, right? Because we know that the fungating wound is there, so there will be a foul smelling will be there. The patient will be having physical disability. Along with that, if malodor will be there, that will also lead to other dimension will be affected, right? Including physical, the other dimension will also be affected. So the wound will also have bleeding, right? Because adjacent, we know as the pathophysiology says, that the adjacent, because of that extra growth of the cells, the adjacent capillary vessels are also disrupted, right? So because of that, the excessive what we can say bleeding will be there. Excessive circulation means adjacent circulation, the capillary everything will be involved, so there will be a risk of bleeding will be there. And also exudate formation, that is there will be oozing from that wound, so exudate fluid will be coming from that wound, so exudate will be there. Itching will be there, that is also a significant finding which is found. The patients who are having a wound, this type of wound has itching also, complaints of itching. Then infestation with the maggots, so we know that the maggots are mainly because of the flies, right? So the household flies that will be sitting on the wound and that will be breeding there. So the infestation with the wound can also cause physical problem to the patient. Then communication difficulties, because of these problems the patient will be having difficulty in communication. They will not be able to express their feelings, right? So next is psychological. So we know that if psychological is hampered, so other dimensions are also that most important. So psychological, the altered body image, right? So altered body image not only in the wound the patient will be having, but in particularly wound the patient will be more prone to get body image disturbance, right? Body image disturbance means while looking to the self and the other people, the patient will be having, why me, I am getting this kind of wound, it has been having pain, I have malodor, I have exudate, everything, and he will not be having that social involvement as he had earlier in the time when he had not this kind of fungating wound, right? So the body image will be altered. Then sexuality, that will also be affected. The normal reproductive age group persons, they will be having sexuality problems also. Then denial, why? Because the first thing, anything happens, the patient psychological will be, no, I don't have this kind of problem, right? So he will be having thoughts that I don't have any kind of problem. So denial will be, that is, denial is a coping mechanism, right? So coping mechanism, everybody uses the coping mechanism, but in this the patient will not be accepting the reality, so that is denial, right? And the fear will be there. The patient will be having fear that now I have cancer wound, it is like this, now I will not be cured, I will die, right? This kind of, anytime I will die, this kind of fear will be hampering his mental status, right? Then depression and anxiety, the patient will be going into depression, and even he can go into the anxiety. He will be anxious about his condition, why this is happening to me now, the maggots will be going inside beneath me. This kind of thought process will be developed. Then he will be having shame also, right? And guilt means, guilt maybe because of, he will be thinking, that means bargaining will be there now. He will be having a bargaining that, if I would not have done this, then I would not have been having this condition, this wound, right? If that single ulcer which I developed would have been treated at the right time, so I would have been cured, right? So this kind of guilt will be there in his mind. And also this guilt will be linked to the other dimensions also. Because of this problem, I am unable to go to the work, and I cannot feed my family and all. So this kind of thought process will be there. So psychologically, he will be disturbed, right? Okay, so social. Okay, social. How, what all things will be there in the social? Family isolation will be there. Why? All the family will be isolated from the society, that that person is having that kind of wound which is having foul smell. The flies are there in that home, and we should not go there, right? So if any kids are also there, that will be scolded, don't go to that house. These kind of things we know that the society will be having, right? So the family isolation will be there. Social isolation, that will be accompanied together with the family isolation. Social isolation will be there. Then social stigma and fear of contagion, right? As I said, there will be fear that if someone will go to that family, he will also get that kind of stigma will be there. Or what if I'll go with this wound, the patient will be telling me, every society will be telling me he is having so and so, and everybody will be staring. These are the communication which we usually get from the patient, right? Then effect of the family will also be socially, psychologically affected. And effect on the sexual relationship and marital disharmony. Because of this wound, there will be patient will be having guilt, fear, everything will be frustrating, and that will be transferred to the least what we can say, least dangerous person as that home. It can be a child, it can be a wife, anyone, right? So the sexual relationship will be affected. Even the patient will not be indulging in the sexual behaviors and all. Then spiritually, what will he will be having? So I am going through this. Can you tell me what will be the spiritual aspect of a person who is having a fungating wound? Anyone? Can anyone respond? You can respond in the chat box, or you can unmute yourself. What are the physical problems the patient will be facing? Already we have discussed it, right? Previous class also, in the case we have discussed it. So the patient will be having a thinking, what thinking he will be having? Why me? God has given me this problem. Why? Right? This thinking will be there or not?
Yes, ma'am.
Okay. Yeah. And and he will be having. Okay, so there will be interference with the religious rights also. So there will be interference of various religions. They will be interfering. Oh, you are having this problem because why? Because you are not following our religion, right? This kind of mentalities are there in the rural areas, more prevalent in the rural areas. And also punishment from the God. He will be telling that this is a punishment, and he will be internally having a guilt that this punishment has been given by the God for me because I have done so and so wrong things, right? And a fear of impending death. He will be having a fear of death also, right? So these are the spiritual, social, psychological, and the physical aspects if a person is going through a kind of fungating wound, right? So what do you think? Yeah, only the wound is having this kind of problem, or any disease can have, right? So any disease can go can affect the four dimensions of the patient, right? So what are the assessment findings? So then when there is a wound, okay. So there is a wound, we have to assess the patient. So what all things we have to assess? That is wound location, where which area the wound is located, right? The mainly in the head and neck cancer, you have seen that the patient will be having a what we can say, a wound in the face, in the mandible area, or in the neck area, right? So that will be more exposure to the outside. eh, like the society can be easily visible. These parts is difficult to cover, right? So even if we are covering the all, the patient will be having a, all the patient, not all the society will be having an eye on us, that oh, he is specially covering, he will be having something, right? So this kind of thought will be there. So when we are doing an assessment in a fungating wound patient, we have to see the location where it is, the mobility is impaired or not, which either the wound where it is located is causing the person to unable to move himself from one place to another. So that mobility impairment will be there and easily covered with the public view. So it can be easily covered or not. These are all things which we have to assess. For example, in the head and neck cancer, right? So, like I had a recent like exposure of a patient who has a fungating wound, right? A fungating wound in the mandible area, right? So he was covering himself. He was having a tracheostomy also, and he was covering himself with a towel. So whenever like doctor asked, you are covering yourself a hole. This area is also covered in the mandible area, and the head is also covered, right? So he already, we know he is having an altered body image. So like we just asked him, why you are covering your face like this? So what his feeling he ventilated was, because everybody is seeing me with a like different like a different creature in this world. Extremely, he used this word only, that they are considering me as a external creature. What is it? And nobody sitting besides me, nobody talking to me. So when I cover it, they are not able to see it, and I can like I can accommodate in the place where I can sit, and nobody is having any kind of problem with that. So it can be easily covered and all. So what he's having a satisfaction that he can cover that area, right? So this is also a point. But the ventilation of feeling is also important. So we can also, even the patients, some patients will be socially isolated, so they will not be covering everything. So we can tell them that you can go out, you can cover it with a good cloth, and that will not be hampering it with your mobility and all, right? So public view, that can be also like we can go to the public by covering that area. So these all assessments we can do easy covering or not. And covering is also very important. Why? Because the flies will sit, right? So we have to tell them that if you are not, you like dressing is also done, but there are certain areas in which the fly can also go inside, so they have to cover it with that, right? So the location is very important. So location is also accompanying two parts. Then wound appearance. Wound appearance means how the wound is appearing, right? That is also very important. Then the surrounding skin. Why? Because if the wound is only take care and the surrounding area is not take care, that will also lead to infection, right? So surrounding skin we have to assess, there is necrosis or not, is there any discoloration or any kind of things is there or not. That surrounding skin has to be assessed. And the potential for complication, any kind of complication like potential for obstruction, hemorrhage from the major blood vessels, that we have to assess. Why? Because in the head and neck there will be a jugular vein, right? So if the jugular vein will be the wound will be extending towards the jugular vein, that will also lead to hemorrhage. So that is also a life threatening condition. So we have to get the potential complication to be ruled out during assessment, right? Then we have to consider some principles of management, right? When we are managing a fungating wound, we have to follow through particular principles. What is it? That is palliation of symptoms. That is, palliation of symptoms means we are dealing with the improving the quality of life of the patient, right? So when we are dealing with the improving the quality of life, we have to consider certain things. What all things? That is, the pain is there, as we discussed in the physical symptoms, pain is there, so we have to reduce the pain. Then control the order and infection. Controlling the order and infection, how we can control, in the earlier class we have discussed it, right? So pain, we can give analgesics, and we can to some extent we can decrease the pain, right? And also controlling order and infection, how we can control order and infection, that is already discussed in the previous session. Can anyone tell? You can use the chat box. Controlling order and infection.
Charcoal.
Charcoal.
Can we use charcoal?
Uh, and proper technique of wound dressing. Okay, wound dressing by using metronidazole. We can even use the metronidazole powder also. So the risk of infection, if it is cured, the odor and the smell, but there will be because it is a fungating ulcer, so their wound, there will be a foul smell. So that is the characteristic difference between a normal wound and a fungating wound. So odor and infection can be controlled to an extent by managing it carefully, right? And also managing the exudate. Why? Because the exudate will also will having pus and all, so there will be foul smell. So we have to manage the exudate also and minimize the bleeding by pressure dressing. And also we can manage the bleeding, or even tranexamic acid we can use, we can minimize the bleeding. And also, so when a fungating wound is there, what are three important principle, four principle we have to keep in our mind is pain, that is reducing the pain, odor and infection, then exudate, that is a fluid discharge or oozing, then also minimizing bleeding, right? So these are the important things. Whenever you see a fungating wound, we have to look into how to manage it. Through these points we have to assess. First we have to ask for the pain, how is the pain, like what kind of pain it is having, the patient is having. And we have to check whether there is a uncontrollable odor, foul smelling malodor is there, right? And also how extent to it is infected. So a limit we can reduce these all symptoms by managing it, right? And also holistic care, that is all the four dimensions has to be involved. And that has to be considered whenever we are dealing with the patient who has fungating ulcer. And also along with the patient, we have to empower the patient and family in wound care. So how to do a wound care? Because what will happen initially, we will be accompanying in the hospital, we will be doing as a nurse, we will be doing the dressing and all. But after the patient discharge, there are limitations, so we have to discharge the patient. So when the patient go home, we will empower the family and the patient both how to manage the wound, how to take care of the wound. These all things we will teach them. So these are the principle which has to be kept in mind when we are dealing with a patient with fungating wound, right? Next, criteria of wound dressing. Okay, so the wound dressing, the main goal will be what? To maintain the quality of life of the patient and maintain and to improve also, right? And through the symptom control. So what all symptoms the patient will be having? Yes, open to you. You can use the chat box. What all symptoms the patient will be having? Four points I have already discussed in the principles. You can say that itself. By reducing the pain, by reducing the oozing, by proper dressing and doing all that, then using of antibiotics. Okay, then
controlling odor and infection.
Controlling odor and infection. Thank you. Then managing the exudate. Yeah, these are all the points which we already discussed. Thank you for responding. Preventing infection. Yes. Okay. So these are the principles which we have to follow it. But that principle will be our goal to deal with that, right? So the goal will be to maintain and improving the quality of life through symptom control, as you have said. What are the symptoms that the patient will be having? So we have to care them with the empathetic care. Empathetic care means we have to consider the patient, that is, consider his feelings, emotion, everything. Then all the four aspects we have to consider, and we have to be in their shoes. Okay, we have to be in their shoes means we have to understand what the patient is going through. With that only we can give them an empathetic care. And also provide a thorough bath before dressing, because the fungating wound has got necrotic cells and all necrotic tissues, that all the tissues will be there more every day, it will be increasing, right? The size will be increasing. So we have to tell them to take a thorough bath before the dressing, so that all that necrotic tissues will be removed by itself during the bathing time. And also ensure the patient had a dose of analgesic before dressing. Why? Because pain control is will be extremely painful, that fungating ulcer, fungating wound. So we have to give them analgesic before dressing. and use normal saline for cleaning the wound. We can use normal saline for cleaning the wound and also select the dressing. What type of dressing? Like if it is an odorous or foul smelling wound, we can use the charcoal dressing, right? But the dressing has to be also cost effective. Why? Because the patient will not be having that much of financial liability. So we have to tell them a dressing which will be more fruitful to them, right? So selection of dressing is also very important. So these are the criteria which whenever we are doing a wound dressing we have to follow. Then minimizing pain. How we can minimize the pain? The pain the patient will be describing will be of different types, right? So as you have already gone through the section, we know there are different types of pain, nociceptive pain, right? So deep pain, that is nociceptive pain, that is aching type of pain, stabbing type of pain, continuous pain, then we can give the analgesic to the patient. So these there will be a systemic adjustments we can do in the analgesic. For example, if the patient has already taken morphine, right? So morphine 10 mg the patient is taking every 4th hourly, right? So whenever we are giving a patient 10 mg morphine for Q4th hourly, every 4 hourly, so at that time in between, like if 6 p.m. the patient is taking 10 mg morphine and next is the dose of 10 p.m. So in between there is any breakthrough pain, we can adjust the use of opioid, right? So how we can say that you can take an extra dose of morphine if you are having a breakthrough pain, right? So that we can adjustments of systemic analgesic we can do if there is a deep pain. And if it is a superficial pain like burning, pricking type of pain, we can use local applications like lignocaine, sensrocaine, these kind of lignocaines local applications we can use in order to superficially sensitize that area, desensitize that area, right? So we can use this kind of management things if the patient is having pain, right? Then malodor. How we can prevent the malodor? By daily cleaning and dressing the wound, right? Then also using a local metronidazole. Metronidazole tablets we can use the tablet, take the tablet, crush it into fine powder, and we can put it with the, if that area is very dry, right? So what we can do, we can use a that powder, along with that the metronidazole powder, we can mix it with liquid paraffin or we can mix it with a Vaseline, right? So there will be less if there is dryness, then we can do that. If already there is oozing and exudate is everything there, then that is not needed, only the powder is sufficient, right? So the malodor can be used by prevented by use of metronidazole locally. And even we can use the IV metronidazole injection also, that is mainly to irrigate the areas, like by taking in the syringe we can flush it there. So in the areas where the short pockets are there in that from getting ulcer, the metronidazole will be going inside, and that to an extent we can control the odor, right? And also use of systemic antibiotic, because these wounds are more prone to get infectious, right? So we can use antibiotics, and also frequent changing of the dressing. So whenever we are changing a dressing, we have to like, I don't know you have noticed or not, these dressing are more sticky in that area. That will be what we can say, all the materials will be sticking to that fungating wound, right? So what we can do, we have to soak it with the normal saline first, then we have to remove that dressing. Otherwise what will happen, the where it will be having a slight pressure, when we will be removing that dressing, that will lead to bleeding, right? Because the blood vessels will be involved, because we know that just in the blood vessels are involved. So we have to be extra cautious when we are doing a dressing to a fungating wound, right? Then also frequent changing of the dressing is important, but consider that we have to soak the dressing and then remove. And also no hydrogen peroxide and betadine, because these are all irritants, so we should not use hydrogen peroxide and betadine. We have to use normal saline, and we can irrigate with IV metronidazole injection. Okay, so bleeding is there. So how we can prevent the bleeding? Bleeding by applying local pressure. Wherever bleeding happens, we can apply a local pressure, right? We do a local pressuring in any kind of wound. So same in fungating wound also, we can apply a local pressure. Along with that, we can give sucralfate powder. Sucralfate powder is an like we use in the peptic ulcer diseases also, ulcer bleeding, we will use it. So in this also, this sucralfate also helps in the preventing the bleeding, right? So we can use sucralfate powder, even we can use tranexamic acid, antifibrinolytics we can use it, tranexamic acid we can use, and also systemic ethamsalate we can use. These all helps to prevent the bleeding. And also palliative radiotherapy we can give. Palliative radiotherapy we can give, and even and one more thing we have to consider, that is dark color cloth. Why? Because if we'll give a white color, normal white color cloth, the patient will be seeing that red color and he will be going into anxiety, right? So in order to prevent that anxiety, we have to consider using dark color cloth. So whenever there is a dark color cloth that is dry, it becomes wet, we can identify that either there will be bleeding or otherwise any exudate will be there. So in especially it is to rule out bleeding, right? So we have to offer them dark color cloth in order to reduce the anxiety or the tension level of the patient. If bleeding will come, they will be in a panic state, right? So in order to prevent that, we have to follow this, right? So the local application we have to do sucralfate powder, tranexamic acid, systemic ethamsalate, and also palliative radiation therapy we can use it, right? So the palliative radiation therapy will be a symptomatic treatment only. That is, mainly we are doing a radiation therapy for what? In order to decrease the size of the tumor, we are giving a radiation therapy. So this will be only for a time being. In order to control the symptoms, we can, in order to control the bleeding, we can use the palliative radiotherapy process, right? Then what is the role of cancer therapy? As I said, the role of cancer therapy, either it is a radiotherapy or it is a chemotherapy or it is a hormonal therapy or a surgery. Surgery, mainly that part is being removed. So therapy, these radiation therapies are mainly wherever the part, the localized area where this fungating ulcer or nodules are there, we are just doing a that area cell growth is been controlled. No new what we can say, new growth that will lead to the size of that tumor will be increased, right? So in order to decrease the size of the tumor, we are using the radiotherapy and the chemotherapy. So radiation therapy is also effective. Cytotoxic chemotherapy we can use, hormone therapy we can use, and even surgery we can do it. That area can be removed. But the thing is, these are all what we can say. To an extent, there are limitations for these therapy, right? Then maggots. This is also a frequent, what we can say, see in a fungating wound or any wound which is being not protected properly or dressed properly will be leading to sitting of the fly, house fly, and that will be laying the eggs on that area, and small maggots will be developed. So how we can prevent it? By using mosquito nets, maintain personal hygiene, and also environmental hygiene. So whenever the patient who is having a fungating wound or any kind of wound, we have to tell them with the education only, we can educate them regarding the use of mosquito nets, preventing maintaining the environmental hygiene and personal hygiene in order to prevent this maggot formation, right? And how we can prevent it? By applying turpentine. We can use turpentine, that is the dressing or a gauze can be soaked with the turpentine, and that soaked dressing can be placed in the wound area, and that turpentine will be helpful to get that because of that smell the maggots will be coming out, and we can remove it with the artery forceps, right? So this is also important. And also physical removal. So physically we are removing with the artery forceps, but we have to what we can say, we have to consider one thing which is very important, is that don't follow the maggots. If you are following the maggots, they will be having a small houses inside the wound, right? So we can say it as a pockets. So inside that pockets they will be running, and if we are following it, if any vessels will be there in between, and the artery will be pricking it and the bleeding will be there. So never ever follow the maggots, right? And also wound should be covered with dressing all the time and changed daily. That is very important. We have to change the dressing daily, and also the wound should be covered with the dressing. Okay, thank you. So this was the topic. Hope you have understood the points. The fungating the fungating wound or cancer wound, which is very important aspect in our palliative setting, because we usually deal with the more cancer patients, and we can see this type of fungating wound. So we have to identify what is the difference between a normal wound and a fungating wound. Thank you. Any questions you can ask? Over to you, Shilpa ma'am.
Thank you, Snehalatha, for the wonderful session. Anybody have any doubts on this, please ask. Anybody? So I have a small request, please switch on your videos. Very good. Thank you. Any questions? Anybody? No, nothing. So, so I have a small question to you all. So, what are the major difference between pressure ulcer and cancer? So, last week we have learned about pressure ulcer. Today we have learned about cancer, that is fungating ulcer. What are the major difference between fungating ulcer and pressure ulcer? So that is the question. Please unmute yourself and talk, or you can put your answers in the chat box.
Pressure ulcer is caused by the pressure created by the bony prominence to the rubbing against the mattresses, and the fungating ulcer is the proliferation and the malignancy of the wound. It's like a there is a difference like the pathophysiology is entirely different in which this is caused, and maybe the pressure also may get proliferated and turn into a malignant wound and may cause like a fungating wound in a
Okay.
long.
Thank you. Any other answers?
Hello,
Yes,
ma'am.
ma'am.
I had just said regarding the maggots, we cannot follow the maggots. We cannot put even turpentine over the maggots also because they are likely to go into the pockets. So then, how to remove them?
So, yeah, so I'll come to that. So we will discuss that first question and we will come to that question. So, I was asking about the difference between the fungating ulcer and the pressure ulcer. So we all know that how the pressure so because of the pressure or unrelieved pressure. The major difference between the pressure ulcer and the cancer wound is pressure sore is most of the time preventable and curable. So the cancer wound is not preventable and not curable. So this is the major difference between the pressure ulcer and the cancer wound. Okay. So and another important thing. So we call usually the cancer wound is a fungating ulcer. So this is not because of fungus. It looks like a nodular fungus shape. That is why we call this wound as a fungating wound, not because of fungus. Okay, clear. So another point, so Lizzie ma'am was asking about the maggots removal. So how does maggots come? How does maggots come?
From the
Okay.
acts of
Due to unhygienic condition, and if the dressing is not done properly.
is unhygienic condition and dressing, if they are not
Doing dressing
the
daily properly.
daily. Okay. Any other answers?
Housefly lay eggs on it.
Yes. So that is correct because of the house flies. So usually the house flies are attracted with the infected wounds. If they touch the wound, they may lay eggs. Within 8 to 12 hours, come out with maggots. So this is the period. So this is the short period that 8 to 12 hours is needed to come with the maggots, with the house fly. So the important thing is the patient and the caregiver doesn't know how does maggots come. If the patient is coming with a wound, any type of wound, you have to talk to them very clearly, proper covering of the wound. So if they are not able to cover the wound or if they are not cover the wound properly, so definitely the housefly will touch the wound and they may lay eggs and come out with maggots. So these important things you have to tell them. If they come with maggots, how to soak. Previously we used to pour turpentine into the fungating ulcer if the patient is having maggots. But nowadays that is not recommended. You can soak the turpentine with the gauze piece or a dressing pad and keep close to the wound. The smell is enough to come out of the maggots. That time the maggots will try to get out from the wound and that time you can do the physical removal. So that is the only way to remove the maggots from the wound. And the another important thing is don't follow maggots. So when if you go with your attorney, usually they will come. So from Snehalatha's lecture, you understand that there are lots of pocket formation inside. Okay, so they will be when you go with your active process, they go inside and keep safe inside the pocket areas. They will be safe there. So if you're following maggots with your active forces will rupture the blood vessels or nerves because we don't know what is inside. So when they come out, you can take it out. Otherwise, you can leave it. So within 5 minutes, they will definitely come out because they will not be able to inside a long time because of their turpentine oil smell. So, Lizzie ma'am, is it clear? Lizzie ma'am?
Yes, ma'am.
Is it clear?
Yes, ma'am, I got the answer.
Okay, fine. Any other questions?
But ma'am, I want to ask you one question is there. If the maggots will come and get attached to the gospice, what about the eggs which are there inside? How will they be
Yes. Your question is not clear. Could you please repeat?
Hello,
Please-
the maggots
yes.
will come with the smell and get this thing stuck to the gospice. But what about the eggs which are there inside? Because we cannot remove with the artery and all, no? We might damage the.
You are talking about the eggs, right?
Yes.
So you will not be able to remove the eggs. If they are in the maggots formation, you can take it out. When they come out, you can take it out. Otherwise, leave the eggs there. Definitely, the eggs will come out with the maggots. So you can give time. So after that, definitely the maggots formed. At that time, you can able to remove.
Okay, ma'am. Thank you so much.
Okay. Any other questions? So, so I would like to highlight few things from today's session. Because the assessment, we understand that this is a non-killing ulcer. From the first day onwards, we talked on palliative, about palliative care is for patient and the family. So if the patient is having a life-limiting illness or a life-threatening illness like this, we need to provide palliative care for patient and their family. So this is a non-killing ulcer and a lot of physical problems. These physical problems will be affecting the family too. So because of the physical problems, the family members will be affecting, they may be abuse the patient emotionally because of you. So we are suffering these kind of problems. So because just imagine a malodor, lot of physical problems, pain, malodor, bleeding, exudate. So these all will be affecting the patient and the family. So what you can do is, we all know that these are the problems, physical problems, they may be having physical problems, social problems, spiritual problems, and emotional problems. So so how are we going to assess these problems? So you have to understand that in front of the caregivers, nobody is telling the truth. They will be hiding the truth. So if possible, you have to talk to the patient individually and assess them properly. So if you talk to them individually, definitely they will be telling the truth. So based on that, you can able to treat them. Okay. So otherwise, if you ask them, so who will be doing the dressings, they will tell my daughter-in-law, or my son, or whatever it is, my mother, or that kind of things. Because sometimes they will have a misconception inside their mind. They will not be, they will be reluctant to touch this kind of wound, because they will be thinking like this wound will spread to them also. This kind of misconception will be there sometimes. But in front of the patient or in front of the caregivers, nobody is willing to explore that truth. So if possible, you can do the individual assessment, then you will get a good picture about the patients. Based on that, you can able to treat them. Okay, so our main aim is to improve the quality of life of the patient and the family. So how we can able to improve the quality of life of the patients? Through symptom control. If you want to do the good symptom control, you have to do the proper assessment. If you do the proper assessment, then you can able to that plan. So that you can plan accordingly, and if your planning is good, then you can able to implement it. That will help to the patient and family for improving quality of life. So you have to think about that. And coming to the pain things, so you have to we have learned about two different types of pain, nociceptive pain and neuropathic pain. Usually, these kind of patients have two different types of pain, because one is because of the direct exposure of dermis. The another one is because of the wounds that size, or that wound will be that growth will be touching or irritating the blood vessels or nerves. That time, the patients will experience neuropathic pain. So you have to, when we do the assessment, you have to do the proper assessment on pain, whether the patient is having neuropathic pain or nociceptive pain. If the patient is having nociceptive pain or neuropathic pain, you have to give a proper medication. Otherwise, then maybe the neuropathic, the nociceptic that pain medications not good for a neuropathic pain. So if you identify this, you have to you can able to give a good medication and give some kind of good satisfactory pain relief to the patient, so that we can able to improve the quality of life. And other all things Snehalatha explained very well, because malodor is one of the major problem here. This will be affecting the patient family too, because of this smell. Nobody is willing to stay inside the home, or that kind of emotional things will be there. So this because of the facial expression, other family members' facial expression, the patient will be affecting a lot because emotional. They will might be thinking like because of my wound, because of my problem, they will be suffering a lot. So why I'm living like this? So please tell me that these kind of questions will be there. They also, if you explore the patient's problems individually, definitely they will be telling like this. So what you can do is you have to try you have to try to control their that physical problems as much as you can. So the drug of choice of controlling malodor is metronidazole. You can use a tab metronidazole, crush it and make it a powder for form and apply, or you can use metronidazole injection. So that will go inside because lot of that pocket formation inside the wound. So that the injection metronidazole will help to inside the pocket formation area and try to help to relieve that. Control the odor, malodor. And the another important thing is charcoal. So charcoal is one of the good agent for controlling malodor. So you can you can use charcoal dressings, but the thing is the charcoal dressing is very expensive, but you can use charcoal. You can do it in your home also. You can take charcoal pieces and keep it in the corner of the room or keep under the bed of the patient. That will help to absorb the bad smell. And also you can think about the home-based charcoal dressings. You can take a charcoal powder and charcoal pieces and grind it well and make it a powdered form and take the dressing pad and apply one layer of Vaseline jelly and the top of that Vaseline jelly, you can pour some charcoal powder and so that charcoal powder will stick on it, and then you can put another the dressing pad on the top, and then you can cover the wound. So that the wound, the bad smell, the charcoal powder will help to absorb the bad smell, control that. So this is the good agent for controlling bad smell. So these are the important things you have to keep it in mind while we deal with the cancer wound like this. Okay, so I think we can move on to the case presentation. Hema will be presenting a patient story today. Hema, so
Thank you so much, ma'am. A very happy good evening to each and everyone, to the presentators and the participants. And once again, I thank you for giving me another opportunity to present a case before you people. And I'm so sorry, my voice is not like very clear. I have a throat infection. If it is not audible, please let me know. Let's move on to the patient story. Patient details. Mrs. Revati, 68 years old, female. She's a case of buccal mucosa, which is like locally advanced malignant wound. She's also a known case of tuberculosis. Presenting complaint, patient presented with a wound on the oral cavity with the ooze, and she had the whole buccal cavity pain, which was radiating to her ear, and also constipation. Bowel opening happens once in 3 days, and insomnia because of pain, and also because of various thoughts going on. Next slide, please. History of illness. Patient is a known case of tobacco chewer since 25 years of age. She developed oral lesions since 8 years, which she neglected and continuing her habit of tobacco intake. She is native medicine practitioner. She uses locally available leaves or some herbs to like for other people. She uses that on her own, the oral lesion also. Once the oral growth ulcer is like very prominent, she visited hospital and was diagnosed with buccal mucosa carcinoma. And then she underwent mandibulectomy with radical neck dissection on Jan 2022. After surgery, she wasn't on any medication. It was like just a symptomatic management after the surgery. Then she was like, whatever she was prescribed, also, she wasn't taking it properly. As she was illiterate, and this native medicine practitioner is like she's doing on her own. Like as we talked to her, she was like telling she was practicing that on the own knowledge, like she haven't taught by anyone, or like she haven't studied. And uh, she she doesn't want to take medicines also, and there is no one else to take care of the patient. Then on December 2022, she presented with the buccal cavity ulcer, locally malignant and extravasating till cheek on the left side. Next slide, please. On examination, patient is underweight, BMI around 17, wound on the left side of the oral cavity, which was extravasating till the cheek, and ulcer was oozing. Poor personal hygiene, patient is disoriented, she don't speak much. Treatment was given. Patient was on tab morphine 10 mg Q4 hourly, and tab sodium valproate 200 mg HS, amitriptyline 25 mg HS, bisacodyl 5 mg TDS, syrup cremafen 15 mg HS, dressing of the wound using normal saline. Psychological aspects, patient lives alone and not interested to participate in any social activity. Patient is quiet always, lack self-hygiene, not participating in any spiritual activity, not replying to the many of the questions which were being asked, speaks only if she feels to, and no source of income other than her native medicine practicing. And she also practices if at all she wished to practice. She's not afraid of death, and she's impending, like she's awaiting for death instead. Medicine already described. She's on morphine, sodium valproate, amitriptyline, bisacodyl, syrup cremafen. Main concerns are pain, improper intake of medicine. She don't have like regular uptaking of medicine, improper nutrition, irregular follow-up, and withdrawal from social activities. Summary, patient with CA buccal mucosa, locally malignant wound, presented with the complaints of immense pain, radiating to ear, not able to sleep properly, improper bowel habits, not taking medication properly, not taking nutrition properly, and self-care deficit, socially aloof, no social income, awaiting for death. Points to be discussed on the basis of the wound, what she presented with, what are the management we can teach the patient and the relatives. Like she don't actually have relatives, like if someone is there, what can be taught or teach to the patient.
Thank you, Hema, for the wonderful presentation. Anybody need any more clarification regarding this patient story? Please ask her. So otherwise we can move on to the discussion points. Anybody need any more clarification? Anybody? So, Hema, where is she right now? She's in the hospital or home?
Mama, I visited this patient. I visited in like we observed the patient. We went for another hospital for few days. There we visited this patient. Like that time she was admitted in that hospital, and after that, like I personally don't know what happened to the patient, but for that week we know the management, what happened to the patient, what was being done.
Okay. So at that time, who was the primary caregiver?
Ma'am, the institute was providing a caregiver to the patient. She came to the hospital alone, and sometimes she speak to some of her relative. She called a sister, and there is actually no one to take care of the patient. Patient was unmarried, and she lives alone. And that house is also not of her own. That was like some government aided house, something like that.
Okay, thank you. So, yeah, so thank you for the clarification. Others, please suggest something. If you have seen these kind of patients in your settings, how are you manage? So are you going to manage this patient? So no primary caregiver, patient is having lot of problems. How will you manage this kind of patients in your settings? Please respond something. Nothing. Yeah. We all nurses now. Definitely you might have seen these kind of patients. Picture. Sometimes previous also.
Ma'am, hello.
Yes, yes.
Ma'am,
Priyanka.
can you admit the patient in hospital because patient is alone and nobody can.
The problem is, yeah, so she said she was in the hospital, but there is no caregiver, some paid caregiver were there. So that's, am I correct?
Yes, ma'am. She wasn't
Yes.
accompanied by any caregiver. The institution has provided a caregiver. Yeah,
Okay, yes. Okay, thank you.
So, ma'am, we can admit hospital.
Yeah, so definitely we will try to admit for or continue this patient within the hospital if the hospital that authorities is permitted, because sometimes paid caregiver is there. We need to, the hospital authorities will need to pay the amount, no? So if they are agree, definitely we can admit the patient in the hospital. But if not, so what is the next option?
Ma'am, trustee hospitals are also there, no? Where they can give free treatment and take care also. They don't require personal caretaker.
Okay. So, you see, where are you from?
Hello,
Yeah, yeah. Where are you working?
I'm working at present at Bombay, palliative care.
Okay. So, okay. Some places have the hospice like facilities available. So that area, the caregiver is not required sometimes. But
Yes,
yeah. So if the hospital or the management request you to uh, give at least one caregiver is required. If we need to admit this kind of patient, then how will we manage? So that all things we need to discuss. So this is a um, unmarried woman having lot of problems as a non-curable cancer. So a lot of we understand that the physical problems, psychological problems, spiritual problems, and emotional problems, social, psychosocial issues and all. So here also you have to put ourselves into their shoes. We need an empathetic mind to treat these patients. If there is no caregiver is there, what is the next step? If there is no paid
we
care,
can get
so,
her admitted and can
okay.
visit her, ma'am.
Okay. Then if there is no caregiver is there, so we expect some that basic care will be given by the caregivers side, no? So all
Yes.
other care will be done by the nurses, but the basic care we will be expect uh, by doing with the by the caregiver side. If there is no caregiver there, so we have to do that basic care too. Here we have receive these kind of patients in our hospital. This is an NGO, Pan in India. So here we have an inpatient facility and outpatient facility and home care facility. So if the patient's problem is not able to, the symptom is not able to control within the sometimes home care settings, we used to bring the patient here with families. So sometimes there is no caregiver. So that time the hospital authority will be providing a paid caregiver. Some in between the the paid caregiver is also wants to go home at least 2 days. I need to go home and come back within 2 days. So that time our nurses will take care of the patient, the whole care. So you have to think about that also. So you have to, if there is no caregiver there, you have to do that part also, the caregiver's part also. So that is one of the role of the palliative care nurse. Sometimes we need to work with the caregiver role.
Yes, ma'am. In our hospital, we keep patient on relative form and all care we nurses provided.
Okay. So how long you will admit?
Uh, in between, their relatives come and see, means in their family, whoever is caregiver, that only person is earning person, then they have to go for doing work. So
Okay.
they keep patient for relative form, and we all take care of them.
So this is a daycare center or a day and night?
No, ma'am. It's like Sipla palliative care in Pune.
Yeah, I know. So, because if the patient wants to go home, so what is the next step? We understand that the uh, family, the earning member, maybe they needs to go uh, to work outside. So because of that, we will admit the patient in the hospice. So that is okay. So on part of caregiver support, we will be thinking like that. If the patient has request you to, I want to go to my home.
Actually, I'm working last 1.5 year in this hospice, but I'm never seen like any patient wants to go home. They like to stay in our hospice.
Okay. So, okay, I agree with that. So why they are willing to stay with you? Why? So we have to identify the cause, because when they go home, nobody is there.
Yes.
Sometimes the morning time they will be alone. So they will be thinking like, okay, if I am here, you all nurses are there, you will be take care of the patients very well. You will be giving food and medications at the correct time, so that he or she will be happy there. When
Yes,
they
ma'am.
go home, so these kind of patients will not get enough care from the caregiver side. So that is why they will be thinking to stay with you. But
Yes.
in a that big family, like so that kind of is times that sometimes they will be requesting us to go to their own home. So what we do is, our main aim is to empower the caregivers too. So when they come to us for some kind of symptom management, we used to train the caregivers too. Like if the patient is coming with the bed sore, if maybe one bed sore will be there, we will teach the caregivers to prevent further deterioration. So that part we need to teach the caregivers about how to change the bed sheets, how to put that all preventive techniques of the pressure sore things we will teach them. And then uh, other than that, we need to teach the caregivers on how to do the dressings. These all things we will teach the caregivers too. So initially they will be reluctant to do it, but gradually they will understand the growth, and the caregiver also wants to go there, no? So once the symptom is controlled, they will go back, and they will be working their own area, no? So they need some kind of support from, so that time when they go home, our home care team will be doing the home care follow-up, and so that the patient and family will get some kind of that support from the home care team. So if the here we have only limited that beds, so that time what we do is, if the most of the time we will try to control their symptoms in their home itself. But if the symptom is not controlled, we will try to get the patient in the hospital, and manage the symptoms within the hospital, and teach the patient family and of the patient, and then send back to their home. And if there is no caregiver, we will try to manage within the hospital, and after that we will admit the patient in the hospice. Like we have a hospice like this long term. So the hospice people will be take these kind of patients long term. So we will connect with them, and we admit it there. And once in a month, our palliative care team will be go there and visit these kind of patients. Yeah. So that's these kind of things we. Any other things you want to add, Snehalatha?
I would like to ask to Hema ji, like what kind of wound the patient had. So it was like wound was a major type of chronic type of wound, or what did you manage? Like what management was done in that setting to cure that wound?
On assessment, the patient had an ulcer, which was from the left side of the lips it started, and it was till the cheek, and it was like open. The wound was like when we saw the patient, it was like almost healthy, but it had oozing. That wasn't pus actually; it was like saliva, because already she had like mandibulectomy, and the scar was there, and from that saliva is also oozing. And it wasn't foul smelling, and it is an ulcer, no bleeding was there, ooze was there, almost it might be saliva. And other than that, wound seems to be healthy at present when we saw the patient. And for the management of that, normal saline irrigation was given, like they were cleaning and they covered the wound, on each shift the wound will be cleaned with the normal saline, and Gospey's paraffin dressing, or like a very wet dressing will be what was used for the patient. And other than that, she was not on any antibiotic painkiller. She was on, for the radiating pain, she was on amitriptyline. And for other complaints were like managed with the medication. For the wound, only the dressing was done like appropriately. Other than that, nothing was done for on that time. And the patient at the home care setup, she was like given psychological support. She was being like assessed psychologically. She might be having like developing depression or something. So she was like actually withdrawing from every social activities that time. And after visiting the home, the institute spoke with the panchayat leader, and uh, they were asked, the neighbors were asked to like help the patient with food, and like a regular visit to her house. So those activities were like done when we were attending the patient that time.
Thank you. This I was expecting, because like only discussing that or knowing the detail will be more beneficial. So whatever Hemaji said, so anything else anybody want to add? What would we have would have done better for this patient? Anything else can be done? So physiological aspect they have touched. They have touched the psychological aspect. Spiritually, she was down, right? She, though she was indulging in her own practices, but as per her mood, right? So like what else we can do in order to prevent, like so socially, the we can call the like we can call the relatives of that person, right? We can have a communication with that person, concerned relative of that patient, and we can talk to them to get a patch up, right? So that they can get she can get a helping hand from the relative itself. So that will be a getting a support from the relative will also be a good psychological support to that patient, right? And what else we can do, like we can also tell them like ventilation of her feeling is also very important, because that will lead to the by touching the aspects before that, we have to have a very good communication with that person, so that she can ventilate her feelings, that how what else things she is going through, right? So that has to be done whenever we in our palliative setting, when a patient is having a wound or any kind of things, we touch every aspect, right? By dealing with the physical, we deal with the psychological. So better thing is we can talk to that patient what else things in our ongoing life, like she was expecting to die, and she was waiting for her death. So why she is waiting for her death, we can ask her. She has a medium that she provide medicines, right? She do her own practices, so she can live the life by doing that, taking that forward. We can give a moral support to her, right? Supporting a single word or a single touch can heal that patient. Like I can tell that 50% she will be having a support by gentle touching that patient itself, right? And with the communication, that will be strong enough, right? So that also we can do it. And like regarding Hemaji said that for the nutrition and all, they have contacted the nearby neighbors and they are supporting her. That is also a good thing which is done. And but the like bowel habits, we can manage it by enema, by giving enema and also adding laxative her daily life, right? And by giving her proper education regarding the hydration and skincare also, we can teach her to do it. If she is not self sufficient, then we can transfer her to the hospice unit, where she can be given better consideration, right?
Thank you, the points. Hema, I would like to ask one more question. Did she get adequate pain relief with the 10 milligram of it?
Yes, ma'am. But the patient is not like so much expressive. So the pain assessment previously she said like she had relief, and after like 10 milligram Q4 thali, she wasn't like after like 5 days she wasn't talk like answering completely that whether she had pain relief or not.
Did she able to write down their problems?
No, ma'am, she was like illiterate.
Later. Okay. Yeah.
No, this is like psychologically, if she want to speak, she will speak, or else she won't. She will keep numb. Like she will say like I'm good. So she won't like express herself much. So it it take a long to like speak to her psychologically, make her like open up and make her speak. It will like take a long time. I feel.
So, yeah, that is the another important points you have to keep it in mind, because if the patient is, this patient is having oral cancer, and sometimes she will not be able to talk fluently because of the pain or ulcer. So that time, if the patient is able to write down their problems, you can give a sheet of paper and ask them to write down their problems. But here, it is not possible because this patient is illiterate. So that time, because what you can do is you can watch her facial expression and non-verbal expression. So then, based on that, you can treat her pain. So that is the only way we can able to manage her pain, uh, especially in head and neck cancers. And what about the nutrition part? Did she able to take oral fluids, oral foods?
Yes, ma'am. She is consuming food was given, but he her chewing is like very hard, so she preferably takes liquids and soft diet.
Okay. Okay. That's good. So, yeah. So here, what you can do is you can, she has some psychological, spiritual problems. Yeah, if possible, you can talk to her relatives like sisters and at least in between also, if they are able to come to visit her, they can come to, at least they can come to visit her and go back. So that also you can think about, you try to talk to the, connect with the family and connect with her. And also, as I said earlier, uh, especially individual assessment. If possible, you can do the individual assessment in front of the patient. The caregivers will not be telling the truth, so they may be hiding the truth all the time. So when if the caregiver the is willing to come to visit her, please you can do the individual assessment and talk to her. And just if they have a misconception there, try to understand that and try to clarify the misconception. So that all things you have to keep it in mind. And coming to the spiritual part, so this is not the religious one. That is also there, but the other things, what their connection, that big connection with the environment or community or relatives, that kind of things will be there. That all come into the spiritual part. So religion, environment, relationship, all those things. So you have, if possible, you can talk to her. If she is able to explore her that expressions, try to talk to her alone. So that's how we can able to manage. So other part, try to involve the community. That all things you did very well. If the caregiver is not willing to support these kind of patients, definitely you can try to include the community people like panchayat member or residents, that kind of people, and also neighbors also. If they are able to, if they are willing to support this kind of patients, definitely you have to connect with them so that the community also will give some kind of support. And also you can think about the volunteers. So if they are, if anyone voluntarily support this kind of patients, you can try to connect with them. And as we discussed earlier, you can think about the NGOs. So if there is a nearby NGOs or hospice there, definitely you have to try to connect with them and admit the patient there, and so that the patient will get a good symptomatic relief from the hospice or palliative care department. So our ultimate aim is to improve the quality of life of the patient through symptom control. So till death, we have to provide a maximum comfort and symptomatic relief. So that is the second aim of palliative care. And if she wants to die, so as Snehalatha has discussed earlier, we have to find out the cause of death because of maybe psychosocial issues. Sometimes the physical problem is not controlled well. Because of that, she is she has own thinking like, oh, why I am living like this? So why? So please kill me like this. These kind of questions they will be asking like this. So if they have some kind of problems inside their mind, they will be thinking like that. So if possible, do the assessment properly and try to explore her emotions. Okay. Thank you. If no more questions, we can wind up the session. Anybody has any more questions? Snehalatha, can we wind up?
Yeah, sure, ma'am. Yeah.
Okay. Thank you, Snehalatha, for the wonderful presentation. Thank you, Hema, for the excellent patient story. So this will help us to, so everyone to think the whole aspects of the patients, especially today's the cancer room presentation, the same patients we got for discussion. So it's very good. You did very well. also try to explore if she is able to willing to explore her emotions, try to explore it so that we can able to improve her quality of life. Thank you others. Thank you all for your contributions. Thank you.
Thank you, Sister Sheba.